Hi, my name is Andrea Tavares, and today I'm going to be discussing low back pain in athletes and the differences between having a conservative treatment versus an operative treatment. More than 31 million people in the United States alone suffer from lower back pain. It is ranked as the number one disease with most years lived with a disability. These numbers range from all different ages, races, physical abilities, and conditions. Athletes, especially, are prone to lumbar injuries due to the amount of strenuous activities that are placed upon the spine. Sprained ligaments, strained muscles, ruptured discs, irritated joints, pinched nerves, and many other mishaps can cause back pain. Degenerative back disorders are the main cause of back pain. For example, degenerative disc disease, or DDD, disc herniation, spondylolisthesis, and spinal stenosis. The spine itself is made up of many parts. The intervertebral disc acts as a shock absorber between each vertebra and keep the distance between them during impact that occurs when you walk, run, twist, bend, or jump. The outside of the disc is known as the annular fibrosus. Its main function is to stabilize the disc and make sure that the spine can properly rotate and resist compression. The inside is made up of a jelly-like substance which absorbs shock and pressure. This is known as the nucleus pulposus. The intervertebral disc is the largest avascular tissue in the body and is the most important load-bearing component of the spine. Over time, these discs begin to degenerate, causing pain down the lower back and down to the lower extremities as well. With degeneration, the annulus begins to tear, making the nerves in the area very sensitive. The nucleus pulposus becomes dehydrated, and the fluid-like substance becomes a solid, making it hard to distinguish from the annulus. Also, when the nucleus pulposus comes in contact with the nerve root, it causes a shooting pain down the legs, known as sciatica. This becomes extremely aggravated when you're bending, standing, walking, or doing any other strenuous movements. Most degeneration occurs in the lumbar spine between the L4-L5 and the L5-S1, which lose their ability to withstand mechanical loads. There are four different types of injuries that occur to the spine. We have soft tissue injury, minor fractures, spondylolisthesis, and herniated discs. With soft tissue injuries, there are sprains and strains that cause tenderness to the area. Bending, twisting, and bearing heavy weights can cause soft tissue injuries. Spondylolisthesis occurs when the facet joints degenerate enough and they become mechanically ineffective, causing the vertebrae to slide onto one another. Disc herniation is categorized into three types. We have protrusion, extrusion, and sequestration. These are very prevalent in athletes due to the nature of the sports that they play and the workload that's placed on their spine. For example, heavy lifting, hyperextension, twisting, and especially direct contact are all high-risk activities because they impart unnatural forces on the spine. 75% of athletes suffer from lower back pain, and of that, 30% is caused by sport participation. 80% of injuries occur during practice, 14 during preseason conditioning, and 6 during actual competition. 70% of lumbar spine injuries that occur in adolescent athletes occur in the posterior elements because their spine are skeletally immature. These injuries are high importance to athletes because they could be the deal breaker in their careers. Low back pain is a cause of about 30% of loss in playing time. The dilemma now lies in how fast they will be able to return to play once these injuries have occurred and which path is better to take, a conservative non-operative treatment or a surgical procedure. Return to play is defined as the athlete's ability to participate in original sporting activities at the same or nearly same level of participation as before. In order to be cleared for activity, the athlete must display a full range of motion, be able to replicate sport activities, and move independently without pain. In a study created to test these parameters, we gathered 250 professional and elite athletes who suffer from lumbar disc herniation and degenerative disc disease. We divided them up into two categories based on who elected to have an operative treatment versus a non-operative treatment. Each patient completed an Artistry Disability Index, an ODI, and a visual analog scale, a VAS. An ODI is a patient-completed questionnaire that gives a subjective percentage score of level of function in activities of daily living, such as pain, self-care, your ability to lift, walk, and stand, your sexual life, your social life, and your ability to travel. Your VAS score is a score of your pain level. As we can see in this chart, depending on how pain is presented, we can determine what may be the possible diagnosis. We are able to come up with a chart that displays the frequency of pain caused by typical aggravators. Walking, sitting, and bending, as you can see, cause the highest percentage of low back pain. The most popular cause of pain is disc herniation. Along with this assessment, a physical took place in order to assess the patient's family history, medical history, and current health condition. Following this, MRI scans were done to assess the disc height, degree of herniation, and the degree of disc bulging, to see which intervertebral disc was most affected. Through this, we were able to assess that indeed the L4 L5 discs were most heavily impacted, as well as the amount of disc height reduction, disc bulge, and protrusion that existed prior to the treatment. Simultaneously, we conducted a study using spinal spines. One of them was modeled as a healthy spine. One had a mild degenerative disc disease, and the third one had a moderate degenerative disc disease. We used these spines to assess the degree of flexion, extension, axial rotation, and lateral bending using MRI scanning in 3 different views. In this graph, we can see that every motion, the L4, L5 discs were most affected and limited in the amount of degree of motion that they could perform. For those that had similar values to the healthy model, we can assume that either the degeneration was not affecting those discs enough or the adjacent segments compensated for the movement. Now that we know exactly what disc to attack, we proceeded with a conservative treatment, which consists of an epidural steroid injection, acupuncture, exercise therapy, spinal manipulation therapy, ice and heat, or a combination thereof. In the spinal category, patients underwent lumbar disc replacement surgery, lumbar microscopic discectomy, and spinal fusion. Spinal fusion was the least favored of the 3 because of many disadvantages for athletes, such as restricted spinal range of motion and a longer rehabilitation period for about 6 to 12 months. Disc replacement surgery aims to conserve physiologic movement at the injured disc while reestablishing disc height and realigning the spine. Discectomy removes the herniated disc from the spine, and spinal fusion fuses the disc space together to limit the motion. After surgery, we placed these athletes in a rehabilitation program that consisted of a postoperative evaluation and active rest. Phase 2 consists of electrical nerve stimulation with minor exercises to work on posture. We later introduced pelvic tilt exercises in order to increase core strength, as well as core exercises to improve balance and coordination. Training the trunk is crucial for maximal spinal and postural stability. Phase 3 consists of sport-like activities to prepare the athlete to return to play. In conclusion to these tests, 81% of the operative patients returned to play for an average of 3.3 years, and 83% of the non-operative patients returned to play for an average of 3.5 years. Of the NFL players tested, 70% of the athletes played in more games post-operative than those who underwent non-operative treatment. Overall, there was not a significant difference between the success rates between these 2 treatment options. However, in a short-term, long-term comparison, with conservative treatment, the spine will eventually begin to dysfunction again. For less severe, short-term cases, conservative treatment is preferred, while in the long term, especially in the case of professional athletes, surgery may be the ideal decision. Although at first it is more time-consuming, the long-term effects outweigh the disadvantages seen during the rehabilitation period.